Thank you to the organizing team for inviting me to speak on this esteemed panel. I'm not sure what Juan Carlos promised you. I left my translation equipment aside, so maybe he's promised you something that I'm not ready to speak, but we'll go again anyways. I want to acknowledge that today I'm speaking on behalf of myself as well as our SE Health CEO, Shirley Sharkey, who couldn't be here. Okay, in the time that I've been given, I will provide a very high-level overview of home health care programs and services in Canada from the lens of Canada's largest not-for-profit social enterprise, and one that has been providing home health and social care services for over 110 years. Yes, over 110 years. We were founded in 1908. I should explain that whenever I use the terms home care, home health care, it's actually all together. So in our context, health and social care, we're talking about that in the same breath. So sometimes I'll say home care, sometimes I'll say home health care, but it actually means the same, and it does include social care. The key questions that I will address are: how are home health care services organized and funded in Canada? Who delivers these services? What are the key challenges with integrating professional health care and supportive social care services? And how are these challenges being addressed? To put home health care in context, let's first start with a quick look at the Canadian healthcare system. So as you may know, that Canada is a federation of 10 provinces and 3 territories. It has only about 37 million people, but it does have the second largest landmass in the world. As a federation, healthcare is a shared responsibility between the federal and provincial or territorial governments. The majority of responsibility, however, falls on the provincial government. The Canada Health Act is the federal legislation that came into effect in 1984. The Act lays out the terms and conditions that the provincial and territorial health insurance programs must meet in order to receive federal transfer payments, and assures universal health care, or Medicare, which actually first started in 1948 and later expanded in 1966. It is important to note that the comprehensive principles of universal health care coverage that are listed in this slide applies to hospitals, physicians and in primary care physicians, as well as diagnostic services. Home care, which in Canada, as I mentioned, includes both professional healthcare services as well as social care services, is not guaranteed under the Canada Health Act. So what that means is that each province has different models of public and private funding. The public funding for home care is targeted, while private services are regulated. There are various healthcare services that are almost all privately funded, as well as seen in Layer 3. I won't discuss all of this in detail, but you can see that home care receives both public as well as private funding. This slide shows the variation of health. Although Canada has, this slide actually shows the governance structure of the Canadian healthcare system. It also introduces other components, which in the interest of time, I will skip for now. But one of the pieces here, I'm not sure, right there, where it says regional health authorities, I'll come back to that because this is really important in the context of home care. I'll discuss that a little later. Although Canada has a universal healthcare system, 30% of health expenditures are not paid by the public purse. Overall, when you consider all of the healthcare costs, we spend about 6,800 Canadian dollars per person per year on health, which is about 11.3% of our GDP, of which on average, each of us pays about $970 per person out of pocket on an annual basis. The top three areas for health expenditures are hospital care, medications, and physicians. This slide shows the variation of healthcare costs by provinces. You can see that in the northern areas, this slide is a little not so good. In the northern areas, the costs are much higher. In fact, in some places, twice as high. And this is largely because of our distances, the harsher climate, and scattered population. So payment for home health care services by household also varies across Canada. The majority of home health care services is, however, paid by government through our taxes. This, however, is impacted significantly when there are stresses on the healthcare funding and governments start to put tighter controls on home healthcare budgets. And as I mentioned previously, because home care is not guaranteed under the Canada Health Act, it tends to be one of the areas that the provincial governments have a lot of flexibility in. And so when there is austerity measures, home health care tends to get impacted. Here, this slide shows one Canadian province's data to highlight the cost differential of receiving care in the hospital compared to receiving care in the home. I'm sure that's no different here in Spain. The average cost of 1 week of care for seniors or elder people in hospitals is 20 times more expensive than the same services provided through home care. In Ontario, as of 2016, over 730,000 Ontarians receive more than 39 million hours of publicly funded home care, while an estimated 150,000 Ontarians purchased an additional 20 million hours of care on a private basis. Also note that for years, the province has allocated approximately 5% of its total healthcare budget towards home health care. So even though home health care is such an important aspect, we are still struggling to get a higher portion of the budget allocated to home health care. To put that into perspective, home health care accounts for $2.7 billion out of the current $53.9 billion spent on health care in Ontario annually. So let's now address who delivers home health care services in Canada. So as home care is organized somewhat differently in different parts of the country, here I will discuss how home care works in Ontario, which is one of the largest provinces in Canada. At the simplest level, publicly funded home care is the responsibility of the provincial government. In Ontario, the Ministry of Health has established local health integrated networks. So in that previous slide where it said regional health authorities, so in Ontario, the Regional Health Authority is this body called the Local Health Integrated Network. It's an arm's length agency of government, and actually in Ontario, there are 14 of them located in different parts of the province. And their role is to assess and determine who receives care, the types and levels of services, and the lengths of time that these services can be provided. I just want to clarify that the local health integrated networks also connect with hospitals and primary care, long-term care, or our nursing homes, as well as home care. The hospitals have agreements with the local health integrated networks. So do the home care and long-term care. In primary care, which is primarily physician-based, they have different funding arrangements, but the planning of how much primary care is required on a population basis is handled by the local health integrated networks. So these LHINs, as we call them, have care coordinators that conduct these assessments for home care and sets the initial care plan. The LHINs have then contracts with organizations like mine, so we're called Service Provider Organization. So my organization, SE Health, would have a contract to deliver the care that the clients require based on parameters set by the LHINs. These contracts stipulates the type of services that we would provide, such as nursing, personal care, rehabilitation services such as physiotherapy, occupational therapy, nutrition, respiratory, and so forth. Once a service provider organization receives a referral, it has limited time within which to accept the referral, usually around 30 minutes. So things have to be fairly efficient, and a limited time within which to contact the client to initiate the services, and usually the target is 24 hours. Depending on the referral request, the appropriate staff are identified and scheduled to conduct an initial in-home assessment and commence the care. And so that in-home assessment is done by the service providers, and then all of the care delivery after that are provided by the service providers. Where a client may require more than one type of service, there may be more than one service provider organization involved in providing care. So in theory, the LHIN care coordinators are required to coordinate the care plan delivered by different care providers from different organizations. I have to say, it doesn't work all the time. So if people think that this is a great system, it works to a certain degree, but it is one of the areas that currently we are re-looking at it in our transformation, and we're trying to change that care coordination to get even closer to the patient. Ontarians can also pay for their own home care and access nurses or other care providers through their service provider organizations directly, so they don't need to go through the government system. And they can hire those services directly from those service provider organizations. But in most cases, even though they may have private insurance, majority of that services is paid out of pocket. However, I should say that in Ontario, and really right across Canada, majority of home care is paid through the public purse. So here, this is just to showcase that home health care services do include all of these different services, and I won't spend too much time on that. Majority of our home health care that we receive referrals for at our organization at SE Health, you can see it comes 60% of that comes from hospitals. And so there is a lot of transitional care that is required. And as our hospital stays of our patients get shorter and shorter, the patients that receive care in the community gets more complex because the patients are much sicker when they're discharged. About a third of the referrals do come from the community, and when I say community here, I mean doctors in the community, so primary care, other community agencies, or direct referrals from patients or families. In the sidebar, you can also see that a large portion of these referrals are for older people or seniors. Earlier, I mentioned the cost overall of health care, but when you just look at home care, the average cost for home care in Ontario, it's about $3,400 a client. So one of the things that's important to note is that although it is primarily a government-funded home health care system, when it comes to standards and quality, they are regulated by government, but these standards and quality are developed by a number of different groups that are involved in the process. So these particular principles that underline all of our home care services in terms of standards and quality are established by the Canadian Home Care Association, which we are part of. The other organization that's important to note is the Canadian Institute of Health Information, which is a national organization that collects and analyzes health system data. Here are the clinical indicators for home health care. So data that we collect through our assessments and our delivery are all aggregated and sent to the Canadian Institute of Health Information that does the analysis and provides reports. In Ontario, we also have an organization called the Healthcare Ontario, which is also government funded, but also an arm's length organization with a mandate to publicly report the quality of healthcare in Ontario. So any one of us, any public, can go on the website and look at what the reports say. And this particular slide, if you can read some of the smaller font, has 4 areas of indicators, and when you click on them, you see various sub-indicators that with various data in it. So integrating services is an important objective for the healthcare system in Canada. I will now turn to discussing some of the critical challenges that impact the level of service integration. It's also always important for me when I come to do any of these types of presentations to indicate what's working, but also what's not working. I think it's important to learn from each other and not just to think that our system is the best. So here I'll talk really in the limited time 3 areas of challenges. Challenges related to who we serve, the talent required to provide the services, and lastly, the policies that pose constraints and limitations. So similar to other developed nations and certainly similar to Spain, Canada's demographics is continuing to change. We are getting older, our health needs are getting more complex, and we use a disproportionately high percentage of our public sector funds to address the needs of people 65 and over. For example, from 2009 to 2014, the prevalence of Alzheimer's disease and other dementias among all long-stay home care patients with a caregiver increased from 19.5% to 28.6%. With advances in therapeutic interventions, individuals that would have died previously from their condition at all stages of life are living longer with their condition. Spending of public health care dollars is highest for Canadians age 65 plus, who account for 17% of the population, which is actually about the same as yours, but utilizes 45% of all public health care dollars. To address these changes, we have seen a big jump in the use of home care services. With this high demand, we're challenged in having the appropriate levels and qualifications of human resources to provide these services. This challenge has created a greater burden on family caregivers to fill in the gaps. Across Canada, the number of informal or family caregivers has been estimated to be about 8 million. And family caregivers face their own series of challenges around burnout, depression, etc. I'm seeing that my time is gone. I'm going to keep moving. Am I okay? Um, so in Canada, one of our big policy barriers that I mentioned earlier is the lack of home care inclusion in the Canada Health Act. As a result, some provinces have created their own legislative frameworks, while others have not. This has given both positive as well as negative consequences. So on the positive side, when you have less legislation, less regulations, you have more opportunity to be innovative and do a lot of experimentation. In Canada, overall, we call ourselves a country of pilots. We do a lot of pilot projects because there's lots of reasons for people to want to try different things. On the negative side, there has been unstable funding, lots of fragmentation that we're constantly trying to address, and introduction of many for-profit players who saw commercial opportunities. In all of this, patients and families are often confused and frustrated and require support in navigating the system, as it is often not clear the responsibilities and accountabilities. It is also confusing for patients and families because they are used to a part of the system that is insured, such as hospital care and physician care, and a part of the system, like home care, that is uninsured and rationed. And what I mean by rationed is each of the provinces determine the targets, and once those targets are met and the funding is no longer there, then the services are either reduced or not available. So how are these challenges being addressed? So I'm going to speak more from our perspective at SE Health. So SE Health is a proud Canadian social enterprise. As I mentioned, it's not for profit. We've been around for a long time. We have about 9,000 staff. We work a lot in terms of partnerships. And some of our strategic focus has tried to address many of these challenges through a bunch of different things. So care delivery models. So I mentioned we do a lot of pilot projects. So as part of being a not-for-profit organization, we have the ability to develop, design with the public in mind, involving the public on various types of care delivery models, including a special focus on transitional care, reactivation, palliative end of life, and daughters and sons of older people. And I specifically mention daughters and sons with daughters first, because as we all know, daughters tend to be, or women tend to be primary caregivers much more. We've also got a research center that we use to conduct our applied research, and in particular focusing on the older adult. We're keeping a forward eye through our futurists to identify and test technology and innovation, and continuously strengthen our talent pool through training and education, as well as other knowledge transfer products. One of the things I want to mention is that we have recently written a book based on our research and reflections on aging called The Future of Aging, which will be available soon. We know that family members who are caregivers have a lot of stress and burden. SE Health has researched and developed many solutions to support caregivers. In particular, many of the solutions are digital solutions such as AI chatbot and interactive online platform. This work is continuously evolving, and we will soon be launching our next generation of ELIZ solutions. So ELIZ is really all about our solutions for caregivers. As I mentioned earlier, SE Health trains current and future home care workforce through a number of methods. We have our colleges, as well as online training, as well as in-house training for our own staff. So this is my last slide. SE Health continues to participate in advocating for a strong home care system and participates actively in strengthening the system. So for example, our CEO, Shirley Sharkey, is appointed member of the Ontario's Premier Council, advising on the transformation of the healthcare system. SE Health is also participating in the design of recent changes introduced by the Ontario Ministry of Health. So as I mentioned before, we're continuing to look at better ways of integration, and one of the ways of integration that has been announced is Ontario Health Teams. So these Ontario Health Teams will receive one source of funding to work together, hospitals, primary care, home care, and long-term care. So right now, our funding comes from different pockets, and now we're looking at more population health-based funding, as well as further integration. Our teams provide significant leadership in this type of endeavor to address and bring both the experience from the field, from people's homes, as well as highlight the voice of our patients. So our journey really is continuing. It's certainly not in any way done. We are continuing to improve our services, and I'm happy to answer questions later on when we have that opportunity. But I also want to mention that I am also leading a workshop tomorrow, and we'll be digging deeper into the specifics. Thank you very much.
Muchas gracias, Tazim.